And welcome to Mahamana case discussion series. And for today's session, we have invited Dr. Navi Mumbai. Satakshi, can please share your screen?
Good afternoon, everyone. Thank you, Asim.
And she'll be speaking on margins in oral cancer.
Give me a minute, please. I'm having little bit of a difficulty in sharing the If I'm audible, just allow me a couple of minutes time till I sort this technical issue. I'm not able to share my PowerPoint. Is my screen visible to all?
Yes, it is visible.
Okay. So good afternoon, everybody again. And Asim, please tell me if we should go ahead. Then,
No, your presentation is not visible.
oh, is it not?
I think you'll have to
My
open your
screen
presentation.
sharing is paused. Okay. It shows my screen sharing is paused. I'm trying again. Is it seen now?
Yeah, it is visible.
Okay. Apologies for the technical glitch. May I go ahead and present?
Please go ahead.
Okay. So good afternoon, everybody. Once again, I'll be talking on margins in oral cancer today. So while preparing for this topic, I was thinking, is this really anything beyond the sacrosanct 5 millimeters that we know for oral cancers? And turns out it is there because of the virtue of margin being the only single most surgeon modifiable factor that is in our hand, which has both prognostic and treatment implications in oral cancer. So we will break this topic down in few simple capsules. That is, what is an ideal margin? How do we achieve an ideal margin? And what are the consequences of not having an adequate margin? So when we go through the literature, turns out that there is evidence for every possible margin cutoff of significance of oral cancer ranging from 1 millimeters to 7 millimeters. So when these kind of varied data comes, we almost always rely on the meta-analyses, and often quoted meta-analysis by Carolyn Anderson came out in 2015, which substantiated which was already known, that is, if we take a margin of around 5 millimeter, then we can avoid nearly 20% of adverse events. That is, 1 in 5 adverse events of recurrence or so can be avoided if we keep a margin of 5 millimeter or more. However, this meta-analysis was again having its own limitations in terms of lack of pathological data, subsite data, and exclusion of patients getting radiotherapy. So the debate was still on. Meanwhile, the NCCN guidelines suggest us that clear margins is more than 5 millimeters. That is the distance from the invasive tumor front to the resected margin. Closed margin is anything less than that. And positive margin is carcinoma in situ or invasive carcinoma at the cut margin section. This carcinoma in situ being considered as positive margin is also corroborated by CAP guidelines, that is College of American Pathologists. In addition to that, also CAP adds a very well debated topic, that is what do we do about dysplasia at the margins. So CAP guidelines suggest that dysplasia at the margin is better reported as a 3-tier grading system, and severe and moderate dysplasias to be considered as margin positive. Mild dysplasia is not considered as margin positive, however, it needs to be reported. And none of these have at present been advised to change any further adjuvant therapy. So this is where we are at. When we wanted to see what is the ideal margin practice and the current trends of margin practice, there are two data sets that we can refer to. One came out in 2005 and another one in 2020. Both were American Head and Neck Society members practice guidelines review. And I have made a comparative bar chart between these two publications, as you see. So by and large, as expected, majority of the surgeons in both the timelines accepted that 5 millimeter or more microscopic margin is where they aim at. But I also want to draw your attention to the second bar that I've created. That is, more and more surgeons are relying on gross margins. The number, even though small, has doubled, and in present practices, many surgeons feel that 1 centimeter of gross margin is adequate enough in their practice. Whether it is correct or no, we are going to see in the data. When we consider an upper limit of resection, we also know that in head and neck, every millimeter counts. Defect size and location has impact on functional outcomes and cosmesis. And we have literature coming out of both India and abroad showing that microscopic margins beyond 7 millimeter does not translate into survival benefits. So to sum it up of what we have discussed so far now, of what constitutes an ideal margin in oral cancer, we can consider a 5 millimeter as of now as a current recommendation, even though it is a concept in evolution. A maximum margin is an interplay of functionality and cosmesis. Beyond 7 millimeter really does not translate into any survival benefit. So how do we achieve this ideal margin? When we are planning a patient's surgery for oral cancer, we rely on preoperative clinical evaluation. We supplement it with 2D imaging. And we also have intraoperative evaluation under anesthesia, add on to the depth. Gross margin assessment by the surgeon and frozen section are the two areas that we also do intraoperatively. So is gross margin planning adequate? So we have evidence suggesting that microscopic disease beyond gross margin is present in only a small subset of patients, 7 to 8% of the patients. And in these patients, half of them may have a change in their resection plan if frozen section is added. If we do not include any supplementation of any frozen section, then adequate gross margin assessment is possible comparatively, 88% and 83%, both by gross assessment and by frozen section. So what this study was trying to tell us is if we aim for an adequate enough gross margin, 7 mm or beyond, then we probably will achieve a 5 mm or so microscopic margin, and we may obviate the need of frozen section in this. When we are planning and talking about 7 mm, 8 mm, we also should keep in mind the factoring in of tissue shrinkage. Tissue shrinkage also depends on the subsite, whether it is on anterior tongue, whether it is a floor of mouth. 20 to 25% of the mucosal margins shrink on table, another 5% based on the technique that we are using, whether it is laser, cold steel, or cautery, and another 10% by formalin fixation. So even though we speak about 7-8 millimeters, in reality it is very difficult to judge it, and we aim for a couple of millimeters more to be safe on the patient's microscopic margin. Now, coming to the question of, does frozen section help? We all know that adequacy of frozen section and concordance with the final histopathology is proven to be high. But what does it mean when we say that concordance with the final pathology is around 95 to 99% of frozen section? What we are assessing is in the same cut. That is, a cut which is analyzed in frozen section is evaluated same in the final histopathology section. But the fallacy of frozen section is not there. The problem with the frozen section is in the sampling error. We will discuss little more on that. And sensitivity of the frozen section, that's how has been found to be low, that is 34 to 60%, but the specificity is high. What does it mean? Simply put, it means is if a frozen section is positive on table, high chances are that it is going to be positive in final histopathology, and we better revise that margin. But having a negative frozen section in intraoperatively doesn't assure the same result in final histopathology based on the sensitivity. So, a better outcome measures when we interpret the frozen section studies should be, rather than the concordance with the final pathology, should be its local recurrence and overall survival impact. So, here we have a study which is often cited again, and many similar studies have published that chances of achieving a clear margin on paraffin section was found not to be linked with frozen section. And frozen section independently did not have impact on local failure or survival. When we factor in cost benefit ratio, both in Indian and outside of India perspectives show that the cost benefit ratio ranges in 12:1 or 20:1. It means that around a small subset of patients, that is around 5% of patients, potentially can benefit from intraoperative frozen sections by virtue of immediate margin revision. We are talking about microscoping frozen sections here and not crossing. Who could be the potential beneficiaries? Potential beneficiaries surprisingly can be early stage lesions or smaller diseases. However, we actually need help of frozen section more for advanced diseases like T3 and T4. Also, re-resection of recurrences, frozen section can be considered. Salvage surgeries are one subset of patients. And when the setup allows a direct collaboration between the surgeon and the pathologist for margin orientation. These are the factors which play direct role on how sensitive a frozen section is going to be. As I was mentioning, the limitation of frozen section is in sampling error and interpretation error. Interpretation error is failure to correctly identify the tissue. This is less. If the surgeon goes and orients it properly, this is less. But the sampling error is the major problem. Small unoriented tissue samples and margins taken from surgical bed adds on to the problems of frozen section. And here we have two studies which are pathologists' perspectives. These are studies published by pathologists where they have pointed out these are the ones which bring down the sensitivity of frozen section analysis. And one interesting study which is known to many of you is by Dr. Cyrus Kerawala. Just to show how fallacious margin reorientation is, they did a small study with surgeons who were asked to resect a specimen. Then they were taken out of the operating room for 5 minutes, and then they were asked to come back and reorient the specimen and take samples from the surgical representative area corresponding to the specimen. Another separate observer was controlling this study. And they found out that the mean error in relocating the sample site when the surgeons came back just after 5 minutes and tried to reorient the sample, they overshoot the margin by nearly a centimeter, that is around 9 millimeters. And how many ever times when we come back to revise a margin, we really go beyond a centimeter? Very less often. So this showed that the error exceeded by a centimeter in nearly 1/3 of the time. Just goes to show the sampling fallacy in frozen section. And probably that has reflected in the survival outcome studies in margin with frozen section. Again, one study by Mustafa Bulbul, which is often cited, and this established that a revised margin from R1 to R0 does not equate to an initial R0 margin. So even though frozen section has its role, but it is not a sacrosanct requirement, and it cannot really undo an initial error in our margin assessment and surgery. So what could be done to minimize these? Couple of hypotheses that were suggested. One of them is analog pairwise tagging. This was a feasibility study done by Dr. Lance Scott, where they had put numbered tags each on the patient side and on the specimen side, and this was done during the resection. And when they wanted to reorient the specimen back with the help of frozen section and revise the margins, it was much easier. This was specifically done for deep margins. So we started adopting a modified version of it because numbering each specimen is really tedious. So we modified this, and what we do is that especially for the deep margin assessment, our areas of interest where we feel we may need help of frozen section, we put paired tags on the specimen side as well as the patient side, so that when we have to come back and revise an area, we know where exactly we need to revise. For example, and in this picture, as you can see. Now, a couple of challenging scenarios. Deep margin assessment. Majority of the times, the inadequate margins are deep. Mucosal margin failures are, isolated mucosal margin failures are very rare. We almost always do the mucosal margins correctly. But nearly 90% of the time when we fail at margin, it is the deep margin. And also it depends on the site: floor of mouth, retromolar trigone, heart palate, buccoalveolar complex. Here is the site where we fail at margin. I want to bring it to your attention that all these sites are the sites where palpation is very difficult, and these are bony prominences. So the deep margin assessment becomes a challenge because palpation is of no help. So how do we assess this 7 millimeters, 5 millimeters intraoperatively? And the second challenging scenario is when there is field cancerization, especially in tobacco related cases. We often get to see pictures like this, where the macroscopic margin assessment is nearly impossible. We have to rely on depth. And microscopic assessment almost always shows dysplasia at margin, and the current margin practices are not optimum to address such field cancerization cases. Another challenging scenario is bone margin. We have couple of described techniques already, like trifine bone drill, thin slices of the bone resection margin with a microtome, curettage of the cortical mandibular bone, cytological smearing from the bone curettage. There are multiple studies which has looked into this with adequate sensitivity and specificity. But why do we find it challenging is they are good at detecting cancellous bone involvement, but the tumors tend to involve the cortical surfaces. And what do we do with superficial cortical erosions or other cortical erosions? That reproducibility of these studies and instrumentation can also be a challenge in some centers. Since we are in an era of neoadjuvant chemotherapy and possibly neoadjuvant immunotherapy, this needs a small point of mention. In almost every conferences, we see that there is no clear answer to it yet. Whoever is interested, I have noted down 2 ongoing trials. You can look it up. One of them has been presented as an ASCO meeting abstract last year as well. It's called Rematch 2201. And they are looking into margins post NACT, and the last one, Rematch, is looking into margins post neoadjuvant immunotherapy. For example, in this picture, as you can see, the pre-NSCT margin often gets blurred in post-NSCT scenario, and we really do not know where to revise it. For example, in this case, when we resected the specimen, even though there is an obvious nodule post-NSCT, this tumor is showing complete response. And this is very different from when we deal with breast cancers and others. If we talk to our breast colleagues, their surgical protocols are pretty standardized. They consider post NACT margin as their resection margin in breast. But those tumor biologies are different from squamous cell carcinoma. Because of patchy regression, we know this is a challenge. So there is really no clear-cut answer to it. Sometimes response adaptive surgery has been suggested. Like if we see a very good response in all the margins in imaging, we may consider going little less on the resection margin, but it is really not backed by evidence as yet. I'll go through just a couple of these recent advances because time will really not allow it. Pathological advances include molecular margin assessment, 3D specimen scanning, and there are a whole array of radiomics and radiological advances in an attempt to increase the sensitivity of intraoperative margin assessment. So this is just for us to have a quick look at it: narrowband analysis, fluorescence dyes, confocal microscopy. But where are we really at with all these molecular margins? As for example, in this picture, as we can see, it extends beyond our gross palpable margin. But why are we not immediately adapting to it? The reasons are: number one, tumor heterogeneity. That is, we really do not know what are the ideal biomarkers to pick when we are scanning for these molecular markers. Majority of the studies have scanned P53, but only 50 to 60% of head and neck cancers demonstrate that. What about the rest? Lack of a standardized panel. And another problem is molecular marker being positive does not really always mean a cancer. Even in field cancerization, the photo that I shared, and leukoplakias, even they sometimes show some of the biomarkers to be positive, and they may show erroneously as false positive markings. Sampling error really could not be avoided even with this. It's time consuming and it is difficult to translate in a real life surgical decision making. As surgeons, we are not always adept to analyze a real time biomarker positivity. So this is right now not a standard of practice in majority of the centers. So this is the second section that we addressed of how do we achieve the ideal margin. We can say safely that adequate gross margin planning, considering subsite and tissue shrinkage, is the current standard of practice. It may be supplemented by frozen section, as NCCN also holds a stand on. It is not an absolute requirement. And close collaboration between the surgeon and pathologist, that is real time going to the pathology lab and reorienting the specimen, is needed when we are considering frozen section. Now, coming to the last section of our discussion, what happens when we are not able to achieve this ideal margin? So the Caroline Anderson meta-analysis came out in 2015 or so. Subsequently, there has been a couple of other meta-analyses to look into the granularity of millimeter by millimeter assessment. So here is one by Curtis Young. Again, they broke down on all head and neck subsites. It's a good number of patients included, more than 2,000. They broke down the margin distances by millimeter to millimeter: 1 to 2 millimeters, 2 to 3 millimeters, 3 to 4. And I want to bring your attention to the local risk reduction. Beyond 4 millimeters, the p-value loses its significance. So what does it mean? That margin beyond 4 and 5 millimeter really does not have much difference. Is it adequate enough for us to immediately change to a smaller margin? Does this study mean that? Probably not. But what it means is, if we see a patient where the patient has come to us with a lesser than adequate margin, maybe a 4 or less than 5 millimeter margin, we still have scope of observing the patient and look into other adverse features before we suggest any adjuvant therapy. There is little bit of a discrepancy here. NCCN, even in present 2026, 25 December 26 version 1 that they have given, still considers positive and close margin as adverse feature and has a scope of adjuvant therapy. So the real question is close or positive margin as a single adverse prognostic factor. When in real life practice we see close positive margins, almost always those patients also have other bad features. These are large tumors, have node positivity, or already has LVI, PNI. So we end up giving adjuvant therapy. But what do we do with cases where only close margin specifically is the only adverse prognostic feature? Do we really give them adjuvant therapy or not? A food for thought here is the famous Bernier and Cooper trials, EORTC and RTOG, had a very small subset of patients. When we look into the data, we will find that only 13% of the patients in URTC and 6% of the patients in the RTOG trial had close or positive margin as the only adverse feature. So when we advise adjuvant therapy to these patients, we have to keep in mind whether they have exponential risk added by other features or not, and also what they considered as positive or close margin in these two studies. The definition was also different. RTOG trial considered tumor margins, tumor at the surgical margin as okay, so the recent two studies, couple of years back, which had come out, one from again Hasegawa's group and another one from Australia, they have suggested that close margin alone really does not require us to jump into any adjuvant therapy, and there is always an exponential risk added. If we have additional features, then probably we really don't need to think much, and we should go ahead and add adjuvant therapy when other risk factors are adding up along with them. So in summary, current recommendations of margin of 5 millimeter does not include tumor biology, location and stage. So there is still some scope of development. Currently 8 studies are ongoing on margin that I could find in clinical trials. 2 of them, as I shared, were on post neoadjuvant margins, and probably a dynamic cutoff value of margin could be considered in future. We have to wait on the data for that. For example, how it is adapted for melanoma, that is larger, more aggressive tumors require a bigger margin, and smaller indolent tumors requiring a lesser margin. Couple of studies have looked into, I have listed them here, have looked into those concepts as well. And to keep in mind that margin is an interplay of multiple pathological factors and not a sacrosanct 5 millimeter that we should decide our adjuvant therapy on. Thank you.
Thank you, Satakshi, for a wonderful lecture, and you have very well covered all aspects. So, if there are any questions regarding the lecture, please put it on the chat box so that we can subsequently answer during the discussion. She is a resident in head and neck surgery at Tata Memorial Hospital, Mumbai. And I'd like to invite the examiners. Dr. Kranthi Kumar. He is a consultant head and neck surgeon at Continental Hospital, Hyderabad. At Tata Memorial Hospital, Mumbai. And Dr. Sambit Swarup Nanda. He is associate professor in radiation oncology at The before Simran or free?
Sorry, Asim, I lost you for a couple of minutes. Is this the question that we are seeing in chat box?
Yes.
Is margin equal to 5 close or free? So the answer to that, as we discussed and I showed the NCCN guidelines, this 5 margin is definitely free. Anything less than 5 can be considered close.
So there is another question. What about the move from
What about the move from specimen-driven frozen section to margin-oriented resection, especially in large tumors? I think this is from Am I audible?
Yeah, you are.
You're audible.
This is my question.
Thank you, sir, for the question. I think we have seen that the practices earlier used to be more from sampling taken from the patient side rather than the specimen driven margin. But there are two straightforward problems with sampling from the patient's body side rather than the specimen. Number one is we can never assess close margins in there because we cannot take a measurement. The only comment that can be made is whether it is positive, having tumor tissue demonstrated or not. So one parameter is already lost in that, and we cannot revise a close margin if we sample it from the patient's bedside. And the second thing is, almost always when we sample from patient's bedside, we take random samples. We cannot assess it by depth where we had been close or where we had been away. So this is not a standard that has been recommended by majority of the studies. It has been found to be lesser adequate than a specimen driven margin.
I would like to just, can you hear me?
Yes, sir.
Yeah, what I feel is, rather, my experience is that the larger the tumor it is more difficult to achieve this FS tumor-free resection in reality. As you rightly said, that
Agreed.
there are several areas where you're very close to uh, the tissue that is not very friendly to assessment by frozen section, for instance, cartilage, bone marrow, and bone, and all that. So as you go towards the bony margin or the tumor inherently is a large one, T3, T4, and you're very close to the edge of the margin, which is also important. What are your chances of error going to increase? And do you advise anything to overcome that?
So, for example, when we are dealing with a very complex infratemporal fossa resection, almost always the specimen after the resection gets disoriented in terms of soft tissue. So one thing could be the surgeon going to the pathologists themselves, reorienting the cover back and asking them to sample the right area. And another way could be also additionally taking some samples of the remaining patient bed if we feel that this is the point where we need to make sure tumor free margin is achieved.
No,
Because
no, what my contention was, if I had 10 T4 or T3 lesions of the tongue near the GT sulcus, okay, and I resect that, yeah, are you going to be going to have a big question mark on the validity and the utility of frozen section, or do you say forget frozen section, we will go in with the the bony margins and achieve a safe margin? That's what I don't think there's been a study done in that context.
correct, sir. So there's no clear answer to it, and almost always we go by the tumor's biology as well. If we feel that it is not a very poorly differentiated or aggressive tumor, and gross sampling is showing us adequacy, we probably won't go and revise and go beyond into the bony margins in a tongue cancer to achieve just 5 millimeters and 6 millimeters additionally.
I didn't mean tongue cancer, I meant areas of oropharynx where it is just impinging onto your coronoid process or your anterior pillar. Those are junctional zones, which
Yes.
not many people do. I know that, but Kidwai we used to do a tons of oropharyngeal tumors. So this is my question based on the experience, large experience there.
Yes, sir. So these are the areas where every millimeter will count. And we will try to make sure that as much as possible tissue we preserve. And unless we are very sure, probably we will not go ahead and aim for anything beyond 7 or 8 millimeters, maybe. This is what my understanding is while being in Kidwai as well. We like to know from you and others as well, sir.
Now let other senior people talk if they are there at the forum. If Azim, what do you feel?
So just margin is never going to be the only
No, no, not the margin only. I'm saying to get the entire thing in toto. How would you try to kind of uh, expedite that so that a large number of them will have negative R0 resection? It is difficult. I'm talking about T3, T4. I'm not talking about T1, T2,
The first
T3.
thing is, sir, the resection has to be anatomical. So when
Yes.
we are looking at a
Go ahead, go ahead.
has to be an anatomical resection, so go much beyond at the insertion of the pterygoid, the
Correct.
upper part of the masseter, so that
Correct.
the tumor is well taken care of, so the margin is free. So that is something must be taken care when we are achieving, when we have to achieve a tumor-free margin.
Got it. Thank you.
One more thing I'll probably add in here, sir, that when we are dealing with critical areas where going beyond a certain anatomy and chasing millimeters is not possible, for example, we have reached the skull base or we are very close to the vasculature or we are at base tongue, we may put surgical clips as markings so that in final histopathology, if by chance we end up having an adverse profile where we need to radiate the patient, we may consider a boost in there.
Yeah, I agree with you. That would expedite the overall treatment of this dangerous spot. I frequently do this. Use Liga clips, titanium Liga clips, and I put two clips if it is serious business. And if it's going toward the foramen, like the foramen oval or something, then I would put three clips and try to orient my radiation oncologist towards dosing that area, and also will think about chemotherapy as well.
Agreed, sir.
So now we'll proceed with the case presentation. Simran, you can please start your case presentation.
Yes, thank you, sir. Good evening, everyone. Today I'll be presenting a case of a patient who had presented to us with a lesion over their tongue, beginning with the same. I'm presenting a case of a 48-year-old male who is a resident of Maharashtra, an electrician by occupation who had presented to our OPD with the chief complaint of a progressive, non-healing ulcer over the right side of the tongue since the last 2 months with pain radiating to the right ear. Um, Going to the details of the history, the patient was asymptomatic approximately 2 months back when he noticed an ulcer over the right side of the tongue, which was insidious in onset and initially pea sized, but has gradually progressed to the current size. With which the patient has presented. It is associated with pain radiating to the right ear. The pain is aggravated on chewing and speaking, and the patient reports relief of the pain with painkillers. There is no the distortion of the sleeping pattern of the patient so far. It is associated with change in the dietary habits, and the patient prefers soft foods which are non-spicy. There is history of excessive salivation also. There is change in the speech that the patient has now started noticing as well. History of dental trauma is present, and subsequent bleeding from the ulcer in the recent past 2 episodes have been noted, which has resolved spontaneously. There is no history of any change in voice, no history of decreased mouth opening, no history of loosening of teeth, no history of any swelling in neck, no history of ulcers elsewhere in the oral cavity. There is no history of weight loss, no history of cough or breathing difficulty or stained sputum or any bony aches. The patient gives history of tobacco chewing for the last 10 years with approximately 1 packet per day, but reports that he's been reformed since the last 2 months. There's no history of cigarette or BD smoking and no history of alcohol consumption. He does not have any comorbidities. He's not undergone any prior surgeries or hospital admissions. There are no known allergies, no previous treatments taken for the said complaints, and no significant family history. To summarize, my patient is a 48-year-old male, a tobacco chewer recently reformed with a non-healing ulcer over the right side tongue associated with pain, which is referred to the right ear, with associated change in dietary habits and speech.
Go ahead, Simran, with the clinical examination.
Yes, ma'am. Proceeding with the general examination, the patient was examined in a well-lit room in a comfortable position. The patient was calm, conscious, oriented to time, place, and person. He was of average build with an ECOG performance status of 0. Vitals were within normal limits, with the patient being afebrile, the pulse rate being checked in the right radial artery of 86 beats per minute, being regular and good volume. The blood pressure measured in the right arm also with a BP of 130 by 80 millimeters of mercury in a sitting position. The respiratory rate was 16 per minute. There was no pallor, icterus, cyanosis, clubbing, edema, or generalized lymphadenopathy noted on examination. On local examination, we proceed with the inspection first. The mouth opening was 4 centimeters incisor distance approximately. They were partially edentulous upper and lower alveolus. The oro-dental hygiene was poor with tobacco-stained teeth present. The tongue range of movements was within normal limits and no deviation was noted. There was a single, approximately 3 cross 2 centimeter lesion over the right lateral border tongue, which was going onto the ventral surface at the level of first premolar to last molar with everted edges and a central necrotic area. Anteriorly, it was 2 centimeters from the tip of the tongue, medially 1.5 centimeter from the midline. Posteriorly, it was just reaching the tonsillolingual sulcus laterally and approximately 1 centimeter anterior to the circumvallate papillae. The tonsil seemed free on inspection. Inferior-laterally, it was just reaching the floor of mouth. The left and the right buccal mucosa, grayish discolored areas were seen with white patchy lesions interspersed. On palpation, the inspectory findings were confirmed. The induration further was felt approximately 1 centimeter away from midline. There was no induration felt over the base of the tongue, the retromolar trigone, or over the tonsil. There were no loose teeth, no induration palpable elsewhere in the oral cavity. Skin all over the face and the cheek were free. On Hopkins examination, bilateral cords were mobile with no lesion noted and no pool secretions in the piriform sinuses, and gag reflex was present. On examination of neck, on inspection, the trachea seems central. There are no visible scar marks or sinuses, no dilated veins, and no visible swellings in the thyroid region or the lateral neck regions. On palpation, the trachea is central with the normal laryngeal framework palpated. Bilateral carotid pulses were there. No palpable swellings in the thyroid region, but there was a right level 1B swelling, approximately 1 cross 1 centimeter, which was hard, non-tender, but freely mobile with rounded edges, rounded and smooth edges. And the overlying skin over the area was free. No localized rise in temperature or erythema. On systemic examination, the chest had bilateral air entry present with occasional added rhonchi, and the CVS and CNS examinations were within normal limit. To summarize, my patient is a 48-year-old male with history of no prior comorbidities, with history of tobacco chewing, with a 3 cross 2 centimeter progressive non-healing ulcer over the right lateral border tongue, reaching till floor of mouth, will palpable 1B node. It is most likely a malignant neoplasm of the right lateral border tongue, clinically T3N1 disease.
Why do you call it T3? Didn't you say it's 3 into 2 centimeters, Simran?
Ma'am, the lesion was much more infiltrative into the substance of the tongue, with it almost reaching till the midline, and therefore I
So at least the estimate maybe you can make that it is infiltrating more than a centimeter. So probably that's
Yes,
why
ma'am.
T3. You can just make it a
T3,
comment.
ma'am.
And
Yes,
second thing
ma'am.
I wanted to ask, it's going onto the floor of mouth, you said, and it's being referred to the ear. So what could be the probable cause?
Ma'am, since there is a shared innervation between um, uh, the mucosa of the oral cavity, which is supplied by either the buccal nerves from the trigeminal or the inferior alveolar nerve in the lower alveolus and the gingiva, and the supply of the external ear, specifically the tragal region, by the auriculotemporal nerve, again a branch of the mandibular nerve. The patient could have a referred pain because of the same.
You think it is the buccal branches and the inferior alveolar nerve that is causing the referred pain to the ear? The lesion is in the tongue. It's going in the floor of mouth. Which nerve is
And the lingual nerve, ma'am. Sorry, the lingual nerve, and
okay? How will you investigate this patient?
um, after the clinical examination of the patient and mapping of
Simran,
the lesion,
may I interrupt you?
you-
Like, what are
I
your
would like to
points to
get.
put it in? Hello? Hello?
Yes, sir.
Yeah, if you have to put it as a T2 lesion, how do you say that it is not T2 lesion? So you said depth and all. So did you try to palpate the lesion?
Yes, sir. I palpated the lesion on the OPD basis. It is much more infiltrative with involvement of more of the tongue bulk, sir.
So
It
if
does
you
not
can
seem
go
to.
back and see your history, how do you want it to put it in T3? So what are the points that are tending to put it in T3 for your history? If you look at the history,
Uh,
you gave a clinical, your history of present illness. In the history of present illness, if I have to put it in T3, then what are the points that are in favor of putting it in T3?
So the patient has difficulties with speech at the moment. The patient has difficulties. The patient has difficulty with the diet that he's taking. He's shifted to a soft diet. So
So what does
possibly
this
much of
indicate?
the.
Like anatomically, what is that you're expecting based on your clinical examination findings and your history of present illness? So what are the points that you wanted to put it as a T3
Sir,
or something like an
considering.
advanced malignancy?
Yes, sir. Considering that there is change in the dietary habits and the speech of the patient, along with the preferred pain that the patient is having, the lesion seems to be much more infiltrative into the tongue bulk, therefore restricting the normal functioning of the tongue musculature with regards to the change in shape or the help with the deglutition or speech, pointing to a advanced lesion as compared to a early smaller disease. And on palpation as well, the much of the tongue bulk feels indurated as compared to just the superficial ulcerative lesion that is seen, indicating towards an uh, infiltrative nature of the disease, sir. Therefore, a T3 as compared to a T2 disease.
Yeah, right. Go ahead.
Dr. Simran, you said that the floor of mouth is involved. So did you ask for the movement of the tongue and how much it
Sir,
was?
it is just reaching the floor mouth, sir. The tongue protrusion is normal at the moment. It is not restricted.
Okay, so both anteriorly as well as superiorly? Tongue protrusion as well as ability of the tongue to reach to the palate? Did you ask for that?
Sir, so the patient was able to approximate the tip to the upper teeth. So far, it is not grossly restricted, sir.
So the question here is probably sir is trying to ask you whether if the patient is having any ankylosing. You feel like you are saying in the history there is an probable infiltration of your extrinsic muscles of tongue, so that he's having that speech and swallowing difficulty.
Sir, no. Despite all that, sir, the patient was still able to protrude the tongue quite a bit. There was no gross ankyloglossia somehow.
Okay, so that grossly doesn't say that the patient, the probability that it will be T3, the chances are reduced if there is no ankyloglossia. No deviation of the
Okay, sir.
tongue, no ankyloglossia, based on just size. So you cannot exactly say that it is going deep and the depth is more than 1 centimeter. It may be,
Okay.
not necessarily, but there are the clinical history doesn't exactly correlate with that.
Okay, sir.
So how do we proceed then if we have such a dilemma? So how do you want to investigate further with this patient?
Sir, I would like to, apart from getting the routine blood investigations done for the patient, I would like to achieve a biopsy from the lesion, and also would like to get imaging done for the patient for the primary as well as the distant metastatic workup, sir. It is a proliferative kind of lesion, so I can, after administering local anesthesia, I can take a punch biopsy from the lesion, and I would like to get a contrast enhanced MRI of the head and neck region. And to evaluate for distant metastasis, I would like to get a non-contrast CT thorax for the patient, sir.
So on contrast enhanced MRI, Simran, what extra information will you get over and above your clinical examination?
Ma'am, over and above my clinical examination, I am able to see the extent of the tumor, specifically the deeper extent, and any involvement and tracking of the disease along the sublingual space, the lingual neurovascular bundle, any satellite nodules along the muscles, external muscles that are um, uh, entering into the tongue, ma'am. I'm also able to um, uh, uh, evaluate the neck, ma'am, regarding the nodes that could not be palpated, owing to their smaller size.
Question is, why not CT scan, contrast enhanced CT scan, and why MRI? What extra information you will get in MRI that you may not get in CT scan?
Sir, MRI has a better soft tissue resolution with better delineation of the musculature of the tongue and the sublingual glands and the vessels and the nerves that would be there in the sublingual space. Owing to the better visualization of the said structures, I would like to get a MRI as compared to a CT.
Also, the perineural component of the disease
Yes, sir.
posteriorly.
Better evaluated on an MRI.
Yeah. So any information that you will get better in the CT scan, which you won't get in MRI, I mean, you will get, but the sensitivity is relatively less.
Sir,
on
CT
this,
is better for evaluation of bony lesions and bone involvement.
in this case, which part of the bone you think might be involved?
Sir, here the lesion is very well away from.
You said the
the
induration was reaching into RMT.
No, sir, it was not.
Okay.
Not reaching till RMT, sir. If it were, then yes, the CT would have a benefit of showing any bone erosion in that same region.
Okay.
So when do you expect a tongue lesion to involve a bone like mandible?
Sir, if there is involvement into the floor of the mouth, and there is abutment with the lingual aspect of the mandible, sir, the patient and paramandibular disease along the same, and
Paralingual
further
disease going
progression,
along
the
the
patient could have.
geniotubercles?
Sorry, sir.
No. You continue. So one point you said is along the floor of mouth into the paramandibular disease. Next,
Yes, sir.
when do you expect
Sir, it
the
could
tongue?
track along the tonsillolingual sulcus, along the tonsils, and also involve the retromolar trigone area and cause bone erosion in that same region, sir.
Is there any difference in the mandibular involvement for buccal mucosa vis-a-vis tongue, or it's the same route of spread?
Good question.
Ma'am, for buccal mucosa, we refer to line of abutment as the common route of spread.
In the tongue case, what happens in the floor of mouth? How does it infiltrate the mandible? Now, what are the genial tubercles? You might have heard about those things. No, superior and inferior genial tubercles. If the disease is infiltrating along the tract.
Correct. Good point.
I'm sorry, sir. I had not thought of the same, sir.
Okay, what will you do in this case, Simran? You have the MRI images with you?
Yes, ma'am.
Okay. Okay, please describe the lesion. Don't read it, just describe it.
Yes, ma'am. Just. Ma'am, on the left-hand side, we have an axial imaging, which is axial T1, post-contrast, and a fat-suppressed imaging for the tongue, in which a lesion is seen, enhancing a lesion is seen on the right lateral border of the tongue, which is not involving the tip, uh, ending anterior to the base tongue, and is almost 1 centimeter away from the midline. It is abutting the lingual neurovascular bundle, but is not involving it at the moment. And there are nodes at the 1B region in front of the submandibular gland and at the level 2 region just behind the same, which have central necrosis, ma'am, suggestive of possibly metastatic nodes.
Very good. Excellent.
So you have to mention the nodes are in which site?
Sir, right-sided neck node, sir. Right-sided submandibular in 1B region and the right-sided level 2 nodes.
So this is the actual you have described. Would you like to comment on the coronal? Does coronal give you any more information?
Ma'am, the coronal imaging helps us see involvement of the floor of the mouth. This obviously would be the radiological floor of the mouth, with the mylohyoid being their limit compared to the surgical limitation that we'll be seeing with the mucosa. It also helps us see the distance of the lesion from the hyoid, how far away it is, and also it will also help us evaluate the abutment with the lingual neurovascular bundle better, ma'am. We are also able to assess if there was further involvement of the floor mouth, we would also be able to comment on the paramandibular disease if any was there.
Will the paramandibular disease involvement change your management plan?
Yes, sir.
How will you, what is the decision making for you if you have to look at your sagittal imaging? Suppose if it is above the mylohyoid or below the mylohyoid line, does it change the management?
Sir, I would have to approach the lesion with a compartment resection if the floor was involved, if the mylohyoid was involved, so as to take that whole muscle and the pathway of spread for the tumor as en bloc resection and be clear with my margins and to take the route of spread from the mylohyoid and the submandibular gland as a single en bloc specimen removed.
Good.
So, is there any other section which you wanted to assess? Like you have shown us both the coronal and so, will your sagittal section help you in making any of the decisions?
So sagittal section also helps us see since the tongue tumors have been described to have more of a longitudinal spread into the musculature, the sagittal sections can help us see spread into the genioglossus, whether or not how closely abutted it is abutting to the hyoid or not. Mostly these, sir.
So, what are the factors that will decide your future course of action, like your neck dissection and the dissection of the primary?
Very good. Excellent.
I'm sorry, sir.
So, what are the factors on radiology that you will look for that will help you to decide on the dissection, say from the
Yes, sir.
point of primary dissection as well as from the nodal dissection?
Very good. Excellent.
So your
Uh,
surgical setting and extent of dissection for primary and node based on imaging.
yes, ma'am. Depending upon the imaging, the structures that are involved would help me decide whether or not I would want a compartmental section for this patient, as already discussed, ma'am. If myloid was involved, I would have to remove the same. If the neurovascular bundle is involved, I would again proceed with the compartmental resection. As for the lesion, whether or not it is close to the midline or crossing the midline, that would also indicate the extent of the nodal dissection that I would have to perform. Then, depending upon the nodes that are there on imaging, their character, if they seem to be metastatic on the side where the lesion is, I would have to proceed with the modified radical neck dissection in view of the multiple metastatic nodes. And if the lesion is reaching midline or crossing midline, I would like to address the opposite neck as well, uh, even if they are, if even if the opposite neck is radiologically negative, ma'am, since the chances of occult metastasis would be higher if a lesion reaches or crosses midline, specifically a larger size lesion or a deeply infiltrative lesion.
Entire extent of the disease, will that make a change in the nodal dissection?
What will, sorry, sir?
Anterior extension of the disease.
Anterior.
Sir, if the lesion involves the tip of the tongue, tip also is known to have a bilateral nodal drainage. Therefore, I would like to address still bilateral neck. If the lesion is going to involve the base tongue posteriorly more so, again, known to have a bilateral nodal drainage. So I would like to address the bilateral neck, sir. If the lesion involves floor, specifically the anterior floor of mouth, again, known to have bilateral spread, bilateral nodal drainage, sir. So addressing bilateral neck.
So Simran, whenever you are dealing with the tongue lesions, I think you want three answers. One is the approach that you are going to take to excise the tongue lesion.
Yes,
Second,
ma'am.
extent of resection. And if you go by the classification, and even you can follow maybe answer. And so what would be your extent of resection and the reconstruction?
Okay,
So
ma'am.
based on imaging and your clinical evaluation, you want three answers, at least as far as the primary is concerned.
Yes, ma'am.
You know?
If I
And
have
then
to put it in another way, when
So
would you
going
like
by
to
the
do?
imaging, yes, sir.
No. When do you want it to do a contralateral neck dissection?
So contralateral neck dissection, if the lesion is reaching midline or crossing midline, if it is involving the tip, involving the floor mouth, involving the base of the tongue, pos metastatic nodes at A level 1A,
Yeah.
multiple metastatic nodes in the ipsilateral neck, or having or a grossly a metastatic node with gross extranodal extension, extranodal spread seen clinically in the ipsilateral neck. I would like to address the contralateral one as well. Going by the imaging currently, ma'am, the lesion has not reached midline at the lesion is away from the midline, and going by the imaging, I feel I could get a good margin by doing a hemiglossectomy, ma'am. And since it is abutting the lingual neurovascular bundle, it is just reaching the floor of the mouth, I would like to go ahead with the en bloc compartmental resection, taking the ipsilateral submandibular gland, the sublingual gland on the ipsilateral side, taking my cut at the midline raphe, along with the ligation of the hypoglossal nerve and the lingual nerve on the ipsilateral side. I would like to proceed with the type 3B glossectomy for him with a right-sided modified radical neck dissection in view of the metastatic nodes that are there, and in view of the multiple metastatic nodes and the lesion, multiple metastatic nodes and the lesion just involving the floor of mouth, I would like to do a selective neck dissection on the opposite side also. The patient, since would have approximately half half the loss of tongue bulk, would require reconstruction with a soft tissue flap, preferably. The options that we offer to the patient would be a FRAF, a faciocutaneous flap, or a FALT flap. If those options are not available, pedicle flaps can be offered, such as a pectoralis major myofascial flap, or a myocutaneous flap, or a pedicle nasolabial flap, islanded pedicle nasolabial flap for the patient.
Just because it is abutting the neurovascular bundle, you wanted to do a compartment dissection. So if you have to put it in clinical radiological staging, how do you stage it now?
Mm.
So going back, you said it is T3N1
Initially, you felt it was T3. Now you have the imaging findings.
imaging. No?
Is the staging the same or what it is now?
Ma'am, as per the imaging, it is
No,
less than
15 minutes.
2.5.
That's good.
Ma'am, it is a T2 disease as per the imaging also.
Then your surgical plan is it's an overkill for the patient. Then you wanted to exercise, do a compartment dissection, put a flap, do a contralateral neck dissection.
Yeah, I agree.
Thing is, do you have evidence that if there are multiple ipsilateral nodal mets are clinically nodal nodes are there, then we need to do contralateral lymph node dissection in the absence of disease reaching up to midline or reaching up to the top or reaching up to the base of tongue.
Sir, there is a retrospective analysis that had seen if there were extranodal extensions in the ipsilateral nodes, and if the tumors were reaching the floor of mouth, they had impact on positivity in the contralateral neck.
So these you are saying about the match pair analysis that are there, who have evaluated that ipsilateral radiotherapy versus bilateral radiotherapy.
Correct.
Depending upon the extent of the disease on the ipsilateral side. And those subgroup were match pair analysis, and that included the oral cavity, that includes buccal mucosa as well as tongue. So particularly anything related to tongue, we don't have in that data.
Yes.
So the consensus around lies with the fact that if, apart from these three factors, that the tumor is reaching up to the tip of the tongue or base of tongue or floor of mouth and crossing the midline, if there are multiple ipsilateral nodes are present and there is extranodal extension, then only the benefit of contralateral RT is there. Even now, in the recent ISTRO consensus guideline, they have further toned down to say that even in these scenarios, perhaps ipsilateral RT is good enough. So multiple studies are ongoing in India as well as in outside, who are evaluating omission of the RT in the ipsilateral side to some extent, definitely omission of the RT on the contralateral side.
Okay, sir.
What is
Would
the
you like
incidence?
to do a EUA for this patient, examination of anesthesia?
Sir, on an OPD basis, I was able to palpate the posterior extent of the lesion well after staying with the local anesthetic. I'm able to map the disease on an OPD basis, and the base tongue was palpable and supple. I can avoid subjecting the patient to a general anesthetic procedure if I'm able to do so.
This is a node positive patient. I just want to know, Simran, what is the incidence of a contralateral metastasis reported in literature if you have a lateralized lesion on the tongue? Are there studies that have reported this incidence? For this scenario, I know this is a node positive patient, but do we have studies that have reported contralateral drainage or contralateral even when it is a lateralized lesion on the tongue?
Ma'am, I'm able to recall the one from the crossing midline paper. Data regarding the lateralized one is not coming to mind, ma'am. I remember Vikramjit sir's paper, but it is talking about lesions that do cross midline. I'm
So
sorry.
let me rephrase it. So you're going to address the ipsilateral neck that we know. Even if it is N0, you're addressing it. We always say that the sentinel node, probably that's a second option that you can do in this case. So that's the added advantage. Now, can you recall any study that have talked about the contralateral metastasis?
Sorry, ma'am.
Something related to sentinel.
What are the trials pertaining pertinent to sentinel node?
Ma'am, we have the SENT trial, one trial done by the Japanese Hasegawa group, and the trial done by the French group, ma'am, Garel et al, ma'am.
SENT have reported the contralateral drainage and bilateral drainage for the lateralized lesions. Okay, no problem.
Sorry, I'm not able to recall.
Okay, no problem. You have excised the lesion, and now this specimen is subjected to frozen section. Tell me about what are you going to look in the histopath report, and how are you going to take a call regarding the adjuvant therapy?
Ma'am, in the histopathology report, I would look at the differentiation for the tumor, the size of the tumor, the depth of the invasion. Then we look at the margins for the resection. We look at the other tissue indicators such as the perineural invasion, lymphovascular emboli, the patterns of invasion, and what is the worst pattern of invasion. What is the tumor budding ratio, the lymphocyte host response that is seen, and these would be for the primary tumor itself. And as for the nodes addressed, we would like to see the number of nodes that have come metastatic, and whether if the contralateral was addressed, whether or not that is metastatic, and whether or not there is extracapsular spread, extranodal extension reported for the nodes, ma'am.
Okay. Tell the absolute indication for the radiotherapy and chemoradiotherapy in this case, in these cases.
The absolute indication for adjuvant chemoradiotherapy would be positive margins, post-resection, or would be extranodal extension of the nodal disease, ma'am.
And
And
for
for
radiotherapy?
radiotherapy, no?
Yes, for radiotherapy, ma'am, it would be stage 3, stage 4 disease. That is T size T3, T4 lesions, ma'am, and nodal metastasis positive in the neck, N1 lesion, or a combination of multiple soft tissue factors. such as presence of penile invasion, along with a worst pattern of 5 and presence of lymphovascular emboli, multiple factors present in the histopathology would also uh, warrant adjuvant radiotherapy, ma'am.
What about depth of invasion?
Yes, sir. Depth of invasion.
So what is the cutoff that we take for giving adjuvant radiotherapy, specifically for tongue?
So depth of invasion. Um, so more than So depth of invasion more than 7 mm along with multiple soft tissue factors you would consider for adjuvant radiotherapy.
That is not true. So that is for buccal mucosa. Usually there is a very old paper which said that more than 4 mm of depth of invasion in case of tongue and more than 7 mm depth of invasion in case of buccal mucosa. In the after that, multiple studies have shown that the controversy rise between 5 mm and 10 mm. Anything less than 5 mm, chances of recurrences without RT are also relatively less. Between 5 to 10 mm, we have the arrest trial, which is almost completed, and we are awaiting the results. Once the results are there, we can say absolutely that whether adjuvant radiotherapy helps or doesn't help. So currently, more than 1 centimeter, definitely adjuvant RT has to be given.
Okay, sir.
There are two questions in the chat box, Simran. So would you consider giving RT if the margin is less than 5 millimeter?
Um, Margins less than 5 mm along with other poor histological factors.
Correct.
Yes.
Correct.
Currently, the evidence is such that if you consider other factors like either LBI or PNI or depth of invasion more
DNIs.
than 5 mm, apart from margins that is 2 to 5 mm, in then the adjuvant RT is indicated. But taking
Yes,
into
sir.
account only the single factor of margin less than 5 mm, the
Is not, sir.
data is not very convincing. Some studies says that there is a significant advantage. Recently, there has been a publication 2024 or 25 where they have analyzed a good number of patients, and the data says that anything less than 5 mm, the outcome is relatively inferior, and that should warrant RT. However, multiple studies from Chen et al. 2013, multiple studies who show that isolated factor that is only margin less than 5
Margin
mm
is
is
not.
not good enough to say that it is very convincingly that adjuvant RT benefits.
Yes.
Is there any role of immunotherapy
Pundigal.
in adjuvant
Um,
setting?
Sir, immunotherapy as an adjuvant setting.
Yeah.
We have two recent publications that have explored immunotherapy in the adjuvant setting for patients. They have looked at pembrolizumab in the keynote trial, ma'am, and uh, in the Nivostop trial, nivolumab has been studied as the adjuvant drug as an add-on to the current regimen also, ma'am. In
But in
the
which subgroup of patients?
yes, sir.
So which subgroup of patients did they take included in the Nivo post-op trial?
Sir, in the Nivo post-op, they've taken the locally advanced head neck squamous carcinoma patients, but patients who have undergone surgery post those locally advanced lesions, and they've subjected them to nivolumab post-surgery, 2 weeks post-surgery with first dose of 240 mg, followed by 3 weekly 3 cycles alongside the concurrent CTRT, and further additional cycles, 6 cycles, sir, every 4 weeks. These all were incremental doses that were given.
So what were the
Start
inclusion criteria? So my question is, which kind of patients did they take for adjuvant CTRT with nivolumab? So now that multiple evidences are coming up, you have to look at the
yes,
inclusion
sir.
criteria. So these studies, they did take the high risk subgroup. The subgroup were, there are 3 criteria. One was ENE positive, one was margin positive, and the third one was multiple sub indications. That was more than 3 sub indications. Whenever they were there, they were taken up for adjuvant CTRT along with
Yes, sir.
nivolumab.
More than 4 nodes involved, sir.
Yeah,
Yes, sir.
yeah. And you have to look at how many patients were positive for margin. That is something which is very dramatic. 60% patients were had positive margins. Okay, now if you have treated this patient on the, what will be your follow-up protocol?
So we would follow the patient up for the first year every 2 to 3 monthly with the clinical evaluation of the oral cavity and the neck, sir. For the subsequent year, 6 monthly. For the first 2 years, every 2 to 3 monthly. For the subsequent year, every 6 monthly, and then annually thereon.
Any imaging which is recommended?
Sir, CT thorax on follow-up.
How frequently you want to do the CT thorax for this patient?
Is there any recommendations to do routine CT thorax without any clinical evidence or any clinical finding?
Sir, if clinical findings are there, we usually do the targeted imaging for the patient. If required, I would also do the MRI head neck. It calls for the same as.
No, if clinically there is no indications, patient is asymptomatic in routine surveillance, do you do any imaging?
So usually at first follow-up, we do end up doing imaging, sir.
So if you are doing a good clinical examination, there is no current recommendations to do an imaging. There is,
Which imaging are you doing at first follow-up of the patient? If you have done the surgery and given adjuvant treatment to the patient comes to the OPD, which routine imaging are you getting done at first follow-up?
At the first 3 monthly follow-up,
You are following up these patients in the OPD, na?
yes, ma'am. We have
You have
gotten
to-
at least.
You are doing routine imaging for these patients in the first follow-up in the OPD for all the patients that you are operating and giving adjuvant therapy.
Not all, ma'am. The
Then how
patients
are
who
you?
had it is more of a subjective thing that was done. It is not the standard.
It
Yes,
is
ma'am.
symptom guided. It is symptom guided. If the patient has a
Yes, ma'am.
symptom, in that case, you will follow up the patient with the imaging. Otherwise, it's the clinical examination.
Correct.
Yes, ma'am.
So you should understand, you have to restage the patient. So what is the chances of this patient having a metachronous for a primary or a second primary? Because he is a chewer.
Tobacco
In
choice,
your
sir.
history, if you
Yes.
go back and if you see the tobacco chewing history is there.
Yes, sir.
So if you understand what is the incidence of a synchronous or metachronous primary or a second primary based on his stage and all, then you can. So what is the annual incidence risk of having a synchronous primary for this patient? Sorry, metachronous primary.
No, sir. I'm
So
sorry.
what
I don't know the
examination
numbers at all.
do for this patient of the follow-up?
Sorry, ma'am.
Apart from the clinical examination, what else will you do for the follow-up when the patient comes for the follow-up? So clinical examination you have told, imaging we have discussed. What extra will you do for this patient?
Ma'am, look at their functional evaluation, whether or not the patient is currently on any of the tubes, and how their swallowing function is at the moment, uh, specifically post adjuvant treatment, whether or not the patient has dysphagia or difficulty swallowing, or any aspiration is there, ma'am.
That's it. You have given radiotherapy to this patient. It's a metastatic disease, so must be N1 or N2, depending upon how many nodes were positive.
Yes, ma'am.
So then, anything else would you want to do in the follow-up?
Ma'am, we do the thyroid profile for the patients.
Okay. Would you send the patient for some rehabilitation?
We would send for shoulder rehabilitation, ma'am.
And what else can happen? You have done extensive surgery with a neck dissection. You have also given radiotherapy. Patient comes to you and gives a history that I am having a swelling in the face in the morning. Then
The
slowly
patient could have lymphedema, ma'am. Post
Mm.
treatment lymphedema. We would also send for rehabilitation for the same.
What is the rehabilitation for the same?
Ma'am,
This patient has given you the history of
ma'am, things like ma'am, lymphatic, like manual massage, lymphatic drainage, ma'am, or so as to improve the fluid, the lymphatic fluid drainage from the regions, ma'am.
Okay.
Also, care for any post-RT if there is adverse skin reactions, care for the same.
So you have given RT to the patient, and the patient has now come with, the brittle teeth, and the teeth are chipping off.
Yes, ma'am.
Mhm. Then
We would also send for the dental rehabilitation with any fluoride application post treatment.
this patient, although he said he is a reformed smoker,
Yes,
will
ma'am.
you guide him for?
We guide him for for de-addiction, ma'am, for counseling, any requirement of nicotine replacement therapies, inclusion of the family in support and to help quit the patient. That we would concentrate, also like to concentrate from the get-go itself if the patient requires help with the tobacco cessation, ma'am, be it nicotine replacement, or if he has more craving or withdrawal with therapeutic management also.
So, Simran, I wouldn't agree with you for a compartment resection, but still, if you have done a compartment resection for this patient, you said you wanted to do a compartment, do a resection, reconstruction, and do a contralateral neck. So, would you like to do the tracheostomy? If, what are your indications for tracheostomy in such cases?
Um,
When would you like to do the tracheostomy?
Sir, it's a um, sir, it's a hemi-glissectomy that I've done, and have detached the genioglossus from the genial tubercle anteriorly. Ipsilateral base has been compromised, but the opposite base tongue and the floor of mouth is well preserved, sir. I can avoid doing a tracheostomy for this patient considering these things. Had I compromised the entire anterior genial complex, or the resection involved bilateral base tongue, the patient would have poorer swallow function and high risk of aspiration, and therefore I would have done a tracheostomy for the patient, sir.
So,
You
if you're
also
doing any anterior tooth-out glossectomy or a subtotal or a total glossectomy, would you like to do any hyomandibular suspension?
Yes, sir.
How would it help
The
you in
patients,
doing that? What is the advantage of doing the hyomandibular suspension, and what is the disadvantage? Like, does it really help?
sir, so hyomandibular suspension is when since we've taken the base tongue away in the larynx word, with the virtue of the tracheostomy and our resection of the suprahyoid muscles, the larynx would fall at a lower level and therefore not have the normal laryngeal elevation when it comes to swallowing, and thus decreased retroflexion and much more exposure of the glottis to the um, swallowed fluids. The patient may benefit with the elevation of the larynx at a higher position with the stitch taken from the mandible border around the hyoid. It has shown benefit in patients who have undergone a wider resections such as neototal glossectomies or total glossectomies, but not so much for patients who have undergone a hemiglossectomy, for the reasons that the opposite side support and opposite side suprahyoid musculature is still patent.
Any study to justify this? In the series paper, Tiwari et al., 1990s, it has been published. So, very nicely it has been described about the hyomandibular suspension and what is the advantage. What you are trying to say is all the points which are there in the paper. So, it's a very well written paper about those hyomandibular suspension.
Hello.
yeah,
Yes, sir.
I think if there are no more questions, maybe we can give her the feedback.
Yes, please go ahead.
Yeah, no more questions from my side.
The feedback.
I think you can start.
Okay,
Very well
well,
summarized, actually, Simran. You have a nice presentation and all, but you need to little more focus on some evidence related, especially when we have to think about contralaterals and trial. This is very like latest trials which have been happening in the Sentinel concepts. So probably that you need to little focus on those things.
Yes, sir.
Otherwise, overall, it was a very nice presentation about your whatever the flow of presentation and everything went very well. And your understanding about radiology is also very well. The only thing is that you are having a lot of answers about your questions, but maybe you need to frame it in a proper way. Maybe with routine presentations and all, definitely you will make excellent this thing. All the best for
Yes,
your
well,
this coming exams.
well, sir. Thank you.
Simran, I think I agree. You presented your history, clinical examination, radiology, everything was very well. One, of course, you need to know the evidence better. That is one thing. Second thing is
Yes, ma'am.
that it's better to reorganize. It's better to organize the thoughts and speak than, just randomly. So initial part was very good, but like follow up, I think it should come in a go how you want to follow up. When you are thinking about the surgery, automatically it has to come in your mind, the approach, the extent, the reconstruction. So a little more
Yes, ma'am.
organized thought is. And the third thing is, by and large, what you are doing in the OPD is what we are asking. So, and you are doing
Yes,
it
ma'am.
every day, and you are seeing more than 100 patients every day. So, it's not anything new that we are asking. That how will you follow up the patients? What are the problems that patients have in the follow up, and all that.
Yes,
So
ma'am.
that is simple, yeah. And there is nothing like subjective. The way you said that it is subjective, nothing is subjective. Everything is driven by something or the other. So maybe what you are doing in the OPD is exactly what we are asking. So I mean, these three
Yes,
comments I
ma'am.
have.
Yes,
But
ma'am.
well presented, huh? Very well presented.
Presentation, the
Yes, ma'am.
the the radiology, every part was okay. You have to just make sure that the rest of the part, that once the surgery is done, how to follow up the patient, what are the toxicities that we expect in the patient, and if the patient is receiving adjuvant radiotherapy, what are the toxicities
Yes, sir.
also expecting to be taken care of a little bit, because when you are sitting and looking at a patient, you will look at the patient in a holistic manner. You have to make sure that
Yes, sir.
all of its toxicities, that including the rehabilitation part, that part has to be
Yes, sir.
explained by you. And you have to look for all the small things, like if the patient is having symptoms related to aspiration, that might be due to the
Yes, sir.
surgical reconstruction, that might be due to the adjuvant radiotherapy, doses received by the DARS muscle. So that is the part that needs to be picked up, and that can only be done by a good oncologist. So that part you have to just make sure.
Yes, sir.
Apart from that, everything was fine.
Thank you, sir.
Congratulations, Simran.
Over to Dr. Asim. Yeah.
Yeah, so congratulations, Simran. So just wait for your examinations and all the best.
Thank you, sir.
Richa, Dr.
Thanks.
Kranthi, and Dr. Sambit for joining, and thanks a lot, Simran.
Thank you,
Thanks,
sir.
Asim.
I'll
Thank
see you
you.
once again after
Thank
2
you.
weeks.
Thank you.
Asim.